Hello everyone, welcome to the clinical case presentation from this week. We have a 6-year-old female spayed German Shepherd dog with a 12-week history of pelvic limb lameness that progressed to lower back pain. So when we start with the observation and you evaluate the gait, but there is other thing that should bring your attention on observing this patient. So overall, look at that tail. That tail, for being the German Shepherd, is not just that it's lower, it doesn't have any tone. You can see there is barely any obvious tone present on the tail, and that is something that already can tell us where potentially the neurolocalization could be. That's not a normal tail tone for a German Shepherd. So when we put our hands on and we do the postural reactions, we can see they are slightly decreased to absent on the right pelvic limb. And then when we evaluate the thoracic, they appear normal. Sometimes dogs do that, so it's very difficult to evaluate if they don't want. The cutaneous truncate was normal. When we do the withdrawal and overall evaluate the withdrawal on the right pelvic limb, just make sure that it's orthopedically able to do it, and there was a good withdrawal on the right pelvic, good patellar, and the tibial cranialis. When we want on the left pelvic, we can see the withdrawal is not as great as it was on the right pelvic limb. So the left pelvic limb has a more obvious reduced withdrawal. It's able to flex the proximal part, but the tarsi is not a good withdrawal, but mechanically is able to do it. So if we do it, you can see there is a flexion, but when we put a little bit of resistance, the dog is not able to do a good withdrawal. Also had postural reaction deficits on the left pelvic limb. Then, as we see, there is a decreased tone on the muscles of the tail, and then the other areas that, and you can see a little bit of plantigrade stand as well. The anal tone is decreased. The anal reflex is present, but slightly also decrease, and the perianal sensation appears normal. So when we deep press with the forceps, you get a normal sensation. When we do the nociception on the tail, because obviously you have a pelagic tail, the nociception on the tail is present. So obviously that's a positive sign. So again, just evaluating the nociception, the dog is able to feel the tail. Then we look for any potential areas of discomfort. Manipulation of the neck did not reveal any obvious sign of discomfort, and then palpating mainly at the level of the lumbar sacral area, we get some discomfort and reluctancy of the dog, and also on the dorsal flexion of the tail, we also find some discomfort. So if we need to go for the neurolocalization, mental status is normal. The gait, it appeared normal gait, but a little bit of plantigrade and low tail carriage with plegia of the tail. The postural reactions were delayed on the left pelvic rim. The spinal reflexes were delayed withdrawal on the left pelvic limb. The perianal tone seems decreased, and then there is some hyperesthesia on lumbar sacral palpation. So we have to neurolocalize considering all these neurological deficits. Where would be your main neurolocalization? And then using the clinical reasoning, we have this 6-year-old female spay German Shepherd dog with 12-week history of pelvic limb lameness that progressed to lower back pain and those neurological deficits that we just described. So we have a chronic, progressive, lateralized, painful, and then you have to consider the neurolocalization. We will see the imaging findings on Wednesday, and then we will discuss the neurolocalization and the treatment and outcome in this case. Thank you so much.